Hi, thanks for joining me at Student Nurses Success today, where we're going to talk about altered blood flow. We're going to cover manifestations of arterial versus venous blood flow disorders and talk about the general causes as well as the most common arterial flow disorders and venous flow disorders. Remember, you can find a link to the maps in the comments section. Let's go ahead and get started. What I'd first like to talk about are the general causes of altered blood flow. With this, we have five main causes. The first of which is atherosclerosis, or the development of plaques inside the vessels. The usual cause of atherosclerosis is dyslipidemia, and we also see an increase in genetics causing high cholesterol levels, which contributes to the development of atherosclerosis. Other risk factors that accelerate atherosclerotic plaque development in the arteries include smoking, lifestyle issues such as diet, uh, lack of physical activity, stress, and we also know that high glucose levels also contribute to the development or acceleration of atherosclerotic plaque development in arteries. When we're talking about cholesterol, we desire cholesterol levels to be less than 200. Now, cholesterol is not all bad. There are some good cholesterol in your body, helps repair tissues, and there is some bad sticky cholesterol that collects inside your plaques. The good cholesterol is your HDL, or your high density lipoproteins. Those are very lighter, fluffier, and they return back to the liver. So they do not get stuck in the arteries. We really want HDL to be as high as possible, greater than 60. Now, LDL are the heavy, bad cholesterols that are real sticky and they get caught and stuck in the vessels. So we want the low LDL or the bad LDLs to be less than 130 or as low as possible. We also know that triglycerides play a role here, and I'll just add those in here. And triglycerides, we want as low as possible. With the development of atherosclerosis, what happens is these LDLs that get stuck in the walls develop fatty streaks inside the vessel walls. As these streaks continue to grow, they start to narrow the vessels. We also know that these fatty streaks cause some inflammation in the vessels, and therefore monocytes will start to aggregate and go to those sites. As the monocytes aggregate on these inflamed fatty streaks, they get harder and oxidize, making the core of the lipid plaque larger and larger and larger over time. We also know that endothelial cell wall damage from things like high blood pressure, stress, and smoking can make the inside of the vessel walls weak. If they become weak, they can start to leak and bleed. And when things leak and bleed, platelets aggregate there, causing clots, which can narrow the arteries also. With most atherosclerotic plaques, at some point, some event generally occurs that causes a rupture of the plaque, whether it be a very stressful event, high blood pressure, or maybe the plaque has just become so large that it finally breaks loose. When it does start to kind of lift off the vessel wall, it starts to bleed and platelets will aggregate there and it will develop into a clot or a blockage. We know atherosclerosis is primarily arterial in nature. Now let's talk about thrombus and embolus. A thrombus is a stationary clot, whereas embolus is a clot that is moving throughout the body, which will eventually lodge and become a thrombus. It will lodge in the first smallest artery that it encounters or vessel that it encounters. Now, arterial thrombus or emboli will disrupt flow to an area. So we will see lack of blood flow distal to where that clot is. With venous problems, we see an issue in the blockage of the return of blood from an area. Remember, venous flow returns blood to the heart. So blood will back up um, from that thrombus or embolus. Common causes of venous thrombus or embolus include immobility, maybe stasis, and trauma, which causes maybe inflammation or the development of a clot. We know with thrombus in the arterial system, we may see the development of stroke. We will see maybe peripheral artery disease contributing to thrombus or embolus, ischemia, and atherosclerosis as well. Now, a vasospasm is only in the arterial system because an artery is the only one that can spasm. Veins cannot. With a vasospasm, you can have a constriction of the artery or the arteriole. It can be sudden or it can be an intermittent problem. What happens with a vasospasm is you stop blood flow to an area. So we will have symptoms of lack of blood flow to an area. Vasculitis or inflammation can be both arterial and venous. When you have vasculitis and inflammation in either an artery or a vein, it will narrow that vein or artery because the inflamed walls start to decrease the lumen size. We can see vasculitis develop when there's injury to an artery or vein. Maybe you inserted an IV and that IV has irritated that vein and caused thrombophlebitis, or disease processes such as Kawasaki's disease or lupus can cause inflammation of vessels and arterioles. Because it is inflammatory in nature, you may have a fever with this. You can also have mechanical compression that can alter flow through both arteries and veins. So, any pressure on the outside of an extremity that can compress and decrease blood flow can reduce flow to or from a location. Let's talk about the common manifestations of arterial issues. When we are talking about arterial blood flow issues, the manifestations are going to be pain from lack of blood flow to an area, decreased pulses to that area. Over time, if we have decreased blood flow through the arteries, the skin will get thin and the muscles will get smaller because of that lack of flow. Patients may complain of numbness, tingling, paresthesias, and the extremities may be cool as well. We also will see decreased wound healing if you have a wound in that area. We'll add that in. Now, venous symptoms are different. And if you think about it, the issue with venous symptoms have to do with the backup of blood. So we will start to see swelling and edema from the impaired blood return. The skin and the tissue will look red, warm, and flushed because blood is pooling in that area and not returning back to the heart. And that's different from arterial, where you start to see cool extremities and paleness. Pulses will be fine with venous problems because blood going to the area is not the issue. It's the blood returning from the area. Patients may complain of aching from the blood pooling, and we will also see poor wound healing, but it's from a different reason. The poor wound healing is from the pooling of the blood and the stasis of the blood, not from lack of blood flow to an area. So make sure that you're clear on the differences between both arterial and venous symptoms. Now let's talk about common arterial disorders of flow. The first of which is acute occlusion. Acute arterial occlusion will be sudden and be marked with profound ischemia, causing pulselessness, pallor, pain, paresthesia, and a very cold extremity. Acute arterial occlusion goes quickly and it is emergent. It can be from a sudden lodging of a clot or a development of a clot or a severe compression that decreases blood flow to an extremity. Peripheral artery disease is another arterial flow disorder. Peripheral artery disease is chronic, and it's usually from ongoing development of atherosclerosis and a narrowing of arteries. With peripheral artery disease, it does develop over time, and the narrowing just continues to get worse and worse. Patients will complain of pain, um, numbness, tingling, weak pulses as well. The pain they often complain of is something called intermittent claudication. Intermittent claudication is usually pain in the calf. Now, when we're walking or using our muscles in our legs, they demand more oxygen to those muscles. Well, if you have peripheral artery disease and you're trying to walk several city blocks, for example, those muscles aren't getting enough oxygen and blood flow to sustain that physical activity. So they will start to hurt and ache, and we call that intermittent claudication. Usually, it'll cause the patient to have to sit down and rest, and that rest will decrease the oxygen demand of the muscles because they're no longer working if you're resting, and the pain will resolve. Patients with peripheral artery disease often have thin, pale skin in their legs or extremities, and if they have an injury or a sore or a wound, it will not heal because they're not getting a lot of nutrients to that area with the decreased blood flow. The third arterial flow disorder is Raynaud's disease. Raynaud's disease does not affect all individuals, but people who do have it suffer from vasoconstriction in the hands and fingers that are brought on by either cold or some type of stress. What happens with Raynaud's disease is they will have this sudden vasoconstriction, and their hands will get blue and cyanotic. And then, when the vasospasm stops, the blood rushes back to the area and it flushes red with that increased blood flow. The problem is this process is very painful when that blood flows back into the area. There's not a lot they can do for it other than maybe avoid cold areas, wear gloves, and just kind of deal with the issue. An aneurysm is the fourth arterial flow disorder I'd like to talk about. An aneurysm is a weakness in an arterial wall. What happens with an aneurysm if they have a weakness in a wall, an increase in blood pressure, or any increase in pressure continues to stretch and weaken that wall to the point where the wall will start to leak or even rupture, causing bleeding or hemorrhage in that area, depending on how large the vessel is. If this aneurysm is in your brain and it starts to leak, they will suffer from a stroke. Other areas, it just really depends, but leaking aneurysms, if they're small vessels, may not be a huge problem if it's not in your brain. However, there is something called an abdominal aortic aneurysm, which is a huge issue. Your abdominal aorta is very, very large. It carries a large amount of blood. And we do notice that as people get older, it does, especially if they have high blood pressure, that abdominal aortic area will start to stretch and weaken over time. And we will monitor this in older adults, especially. If that abdominal aortic area gets so enlarged that it's greater than 5 to 6 centimeters, that aneurysm, we will actually go in and electively patch that so that aneurysm does not leak or rupture. If an abdominal aortic aneurysm leaks or ruptures, it is an extreme life-threatening emergent event. So we really don't want that to happen. Now let's move on to disorders of venous flow. The first I'd like to talk about is just valve incompetence. With the veins, you have valves in them that keep the direction of blood flowing back to the heart. What happens is sometimes these valves get weak and stretch out and they don't work. And as they get stretched out, it actually increases the width of the veins and it offers an opportunity to flood for blood to actually get turbulent in that area and maybe not even flow correctly. So valves direct the flow of blood back to the heart. Things that stretch valve out include maybe standing, maybe weight, obesity, pregnancy. Over time, valves that are incompetent will turn into something called varicose veins. Varicose veins are very wide veins where the valves are not working very well. Blood is kind of turbulently flowing through the area and actually causing stasis, and eventually clots will develop in this area. They get very, very wide. We see individuals who have occupations where they stand a lot, maybe nurses, because we're on our feet so much. Maybe if you have increased weight, that can stretch those veins out and make those valves incompetent, even pregnancy. Over time, that impaired venous return can lead to stasis, and stasis will eventually lead to clots that develop. If that clot breaks loose, it'll be an embolus and it will lodge in your pulmonary system because that's how blood returns back to the heart. Now, chronic venous insufficiency develops over time in individuals who maybe have some occupations where they've stood a lot. Maybe they have a lot of varicose veins. Maybe they have some valve incompetence. In these particular cases, this is just chronic over time. Blood flow back to the heart is just not very good, and blood starts to kind of collect in those legs. What we see in those individuals is edema, swelling, redness, and warmth, which we see as symptoms of venous issues. What we most worry about is clot development, because if those clots break loose, they can lodge, or if the clot is large enough, it can obstruct flow. If we develop a clot in one of our deep veins in our legs, one of our very large veins, that would be a very large clot that develops there, that clot can break loose and lodge in our pulmonary system or in our lungs, causing a pulmonary emboli. Now, pulmonary emboli is discussed in one of our respiratory videos, so refer back to that for manifestations of a pulmonary emboli. When people develop DVTs, it's often in a situation where they are immobile. That immobility, we know that physical movement, muscle contraction actually helps direct blood flow in your veins back to your heart. So if you're not moving your legs, pumping your ankles, or moving around, you can get some stagnant blood flow in the venous system in your legs. And stagnant flow causes clots to develop. If you develop a clot in one of your deep veins and it breaks loose and lodges, patients can get really sick with a pulmonary emboli, have difficulty breathing, and even can cause mortality. What we will see in patients if they develop a deep vein thrombosis is redness, swelling, and warmth, usually in one leg. So it's real important to do your side-by-side assessment of their legs if they are immobile, especially, or if they have decreased activity levels. You'll actually see that leg get really red and swollen if a clot is starting to develop in their venous system. Prevention is key. We want to improve venous return. Sometimes we put anti-embolism stockings on them. They may be taking heparin or some type of anticoagulation to decrease clot development. And certainly, if we can get them up and moving, that's going to decrease the development of DVTs. The last I want to talk about is thrombophlebitis. When we insert IVs into our veins, those are small vessels, but the actual IV catheter can irritate that vein, causing inflammation. That's the phlebitis, and sometimes a small clot can develop in that area. These are usually in superficial veins. They do hurt a little bit, but they're usually not life-threatening issues, but they can become infected. So thrombophlebitis is usually related to an IV that's maybe irritating a vein. So there you go. There is our completed map. I cannot stress how important it is to make sure that you know the difference between manifestations of decreased arterial flow and manifestations of venous flow. They are very different, and they will really help you identify where the problem is in your patient. Thank you for visiting us today on Student Nurses Success. Make sure you subscribe and like our videos to keep up to date on all our new ones.